Good afternoon and welcome to today's Hospice News webinar, Transform Your Approach to After-Hours Phone Triage, sponsored by IntellaTriage. My name is Jim Parker, I'm editor of Hospice News, and today we'll be talking about an emerging approach to leveraging after-hours triage designed to increase nurse efficiency, reduce staff burnout, and give providers access to key metrics. I am pleased to introduce today's speakers. We have Christy Samuel, Senior Director of Clinical Services for Three Oaks Hospice in Dallas, and Daniel Reese, CEO of IntellaTriage. Christy and Daniel, thank you both for being here.
Thanks for having us, Jim.
Thanks.
Thanks, Jim. So Christy, you want to just do a brief introduction of yourself, and then I'll do me, and we can start moving forward.
Okay. My name is Christy Samuel. As I was introduced, am a Senior Director of Clinical Services for Three Oaks out of Dallas. I have been a nurse for 18 years in hospice exclusively for the last 16 plus. I've done everything in this field from case management to triage to on-call nursing. I've worked as a patient care manager. I've done a lot of different things, and now I'm a director over all of the clinical services for the Dallas office.
Excellent, thanks, Christy. So hi everyone, I'm Daniel Reese, the CEO of IntellaTriage. I wanted to give a little background. So IntellaTriage has been serving the hospice clients since 2008 when we were founded, making us one of the oldest triage companies in the country. Today we do specialize in the post-acute care segment of the market, and our services kind of continue to evolve as that segment of the market has evolved. I've been with the company since 2019 and oversee the overall strategic direction of the company while also pretty heavily allocating my time to the day-to-day operations of the service to make sure we're serving our clients well. Prior to IntellaTriage, I worked in a variety of different operating roles, but I started my career in the U.S. Navy as a nuclear submarine officer. So excited to be on this webinar with all of you today and hopefully providing some educational material for everyone to think about. With that, we will just jump right in. So, given that all of you are joining the webinar, I'm sure that everyone's kind of aware of the state of the nursing shortage, especially in hospice, but we wanted to kind of introduce a few fast facts here to truly highlight the severity of the situation. So number one, some stuff that I think surprised me from some recent surveys, and we'll get into some focus groups here in the next couple of slides, but we have a average turnover rate of hospice nurses right now of 22.8%. which is a little bit wild if you have a staff of 20 nurses on average, you're going to turn over 4 every year. And with the cost of that, there's ranges depending on where you live and the training regimen you have for your staff, but the range that was provided in that survey was $33,000 to $56,000 per year. So for those 4 nurses every year, you can expect to spend approximately $180,000 in recruiting, training, and administrative costs of getting those nurses, your new nurses that are turned over, trained up and ready to provide service. Finally, with the expected growth in demand for hospice nurses, which is expected to be around 20%, there are really no signs of the problem slowing down. Burnout is kind of the #1 reason for turnover, and the rate could actually accelerate for the hospices who don't have a plan in place for the nurses to be satisfied and keep engaged with their organizations, which is one of the things we wanted to just kind of highlight today is how we could potentially work with you to improve that. So another interesting fact about some of the most recent studies is there was a focus group that was conducted with hospice nurses specifically, and this was very surprising to me. But the fact that patients are dying or that patients and families are suffering was not actually mentioned at all in this focus group of a direct source for burnout. Obviously, it was mentioned in a variety of other factors, but as far as it contributing to burnout, it didn't play a role. It was actually the structural and administrative characteristics of the work that was being done that led to the burnout, which I think was surprising to me, and Christy and I discussed it. I think it was a little bit surprising to her as well. So, I think we wanted just to kick off our session today with a question for the audience and understand kind of what your perspective is on this topic. So how much do you think after hours care contributes to nurse burnout? And I think there's a poll that will go live now. Is that right, Jim?
Responses are still coming in. Right now we have 73% of respondents saying that it's a major contributor. 18% say it is the main contributor. We have 4% saying that it's a minor contributor, 7% said they're not sure, and no one has said that it's not a contributor.
Excellent. Okay. Talk a little bit more about that. So I think number one, this is interesting for me because, when we have our discussions with potential customers or people at conferences, I think it's something that we don't usually get as a response of a major or main contributor. So this is interesting to hear that this group is highlighting this as a main or major contributor. And we'll collect those poll results and kind of send them out. But thanks, Jim, for kind of sharing that. I think as we kind of go through this, it's interesting that this group is thinking that, hey, this is actually a major contributor. And we wanted to highlight kind of from our internal data what we think is interesting information and actually a little bit of a question we asked in all of our sales meetings that we get interesting response to. So there's no poll here, but just a question for you to think about and kind of keep in your head a number here. So how many after hours calls do you think, if you have a 250 patient census, you would receive during an average week? And I'll ask Christy to chime in here as well, because we talked about this and curious, I want her to share her answer with the audience as well.
Yes, because I was surprised for sure. So just to give y'all an idea, our census is about 230 to 240. And I was just kind of like quickly trying to analyze the reports that I get from IntellaTriage during the week. And I think 110, I believe is what I guess, between 110 and 120, which I was wrong.
Well, so it is, I think it is one of those things that we see pretty regularly as an underestimation of how many calls you would expect for 250 patient census. So the answer that we would say we see across our entire census on average is around 222 phone calls for a patient census of 250 patients. So think about that just for 1 second. On top of all the other things that your after hours or on-call staff are having to do, they must, at a minimum, whether you use an answering service, whether it goes directly to them, at a minimum, they have to be aware of 222 other calls that are coming in during the week that they have to in some way process, whether they have to take care of it now, something that it waits till tomorrow, and that really just contributes overall to this after hours burden that we see. I think going in a little bit further and going back to kind of overall what we see as far as after hours contributing to burnout, we wanted to provide just a few other stats that it stands out to us, but I think a lot of times people don't necessarily think about it in the same way, which is 75% or 123 hours of a total week is after hours. And unlike other healthcare settings like primary care or provider groups or at a hospital, the distribution of times that something could come up medically that you need attention, I'll speak kind of from personal experience here with hospice with my father, is it doesn't really matter if it's 3 a.m. or 3 p.m. If something changes or you need some guidance because there's an unfamiliar situation, really doesn't matter what time of day it is. So that 75% really is the true kind of amount of time in the week that a patient or a caregiver could be needing a little bit of help. And if they're waiting a long time or your nurses are getting on another call, it can just contribute overall to that patient experience and the satisfaction the care they're getting. So we also wanted to dig a little bit, just so again, sharing a little bit of internal data of what this looks like for an average week. So the chart here, you have the red is our weekend call volumes and the blue is the weekday call volumes. We just layered it and said, hey, during the course of a day or during the course of a week, based on weekend or weekday, what does the distribution of calls look like for an average customer that has a 250 census patient census, excuse me. And what we see here is, we think about tactically about this. We see the highest call volumes during the parts of the day when your team, especially if they're part of your daytime team, is really trying to wrap up their day or have dinner with their families. So if you think about the 5 p.m. and 6 p.m. hours here, so we by the way, we adjusted this for local time. The 5 p.m. or 6 p.m. hour here on this chart is showing it's the highest call volume. It's right after the office typically closes and right when on-call nurses are starting to get those calls. And so what you see is just right when nurses or staff members or the whole team is really trying to unwind and maybe have dinner with their family, you're getting the highest influx of calls. We also see this on the weekend. I mean, I have a daughter myself, and so I think about a soccer game on a Saturday, and all of a sudden now you're getting calls right in the middle of the day if you're on call, or maybe you have to miss the soccer game because you have to take all these calls. So it can be a huge stressor just from the day-to-day of what you're actually having to miss or give up in order to be able to address these calls, and can significantly contribute to their burnout. I also wanted Christy just to kind of weigh in here on, Christy, me and you talked about just kind of, what you see day to day with your team. Obviously, you utilize IntellaTriage services, but just how your nurses are feeling kind of generally, irrespective of what happens after hours on the day-to-day stresses of the job.
For us, like everyone, we've been dealing with COVID, since the start. And that was a huge stress to our patients, our families, our nurses. The nurses, of course, were worried about it because of their own personal selves, their families, and then worrying about their patients. And being a hospice nurse, or anyone in hospice, you feel like you need to be there 24/7 for your patients. So our nurses were not only exhausted and stressed, they were also just tired. They, feeling like they needed to be available constantly, but they haven't had to be available constantly because of IntellaTriage. Which, I think we're going to talk about later on, but this is one of the great benefits that we've experienced with our staff, especially right now during COVID, is when they're done with their day, they're done. They can turn off their phones. They send us a report. We pass it on if we need to. And they don't have to worry about answering that phone after 5 or, waking up and making sure that they didn't miss a message from a family at, 2 a.m. They actually can relax. They can go home, be with their families, document, because we all know they're probably documenting at that time too. But they can truly just stop working. So that's a good benefit, very good benefit.
Yeah. Thanks for that context, Christy. And I think, the takeaway here is just that regardless of after hours, there's enough stressors during the regular day that it contributes significantly to nurse satisfaction levels. So, we'll kind of move from here of kind of, hey, here's the problem and the real burden of after hours into, okay, so what are the common models to address this, and how does IntellaTriage play in that arena? So this is another poll, and again, this is, I think, more for data collection purposes for us, but would be very interested to kind of, hey, what is your current approach to after hours? I think these we see the most common approaches to after hours. There should be a poll, I think, going right now, and I'll give everyone a few seconds to fill that out. But really, what we're trying to do here is highlight the most common models and talk about. Christy's going to jump in here in a minute and just talk about her experience with a few of these models. I think the answering service model in particular, and we can talk through kind of what that looks like on a day-to-day basis. Jim, do I need to wait here for the poll to be answered, or are we okay to kind of move through with the poll? Will the poll stay up?
It looks like responses are still coming in pretty quickly. I might give it a few more seconds.
Absolutely, we'll give it a few more seconds. And Christy, if you want to go ahead and kind of jump in, I know you have some experience with an answering service prior to Three Oaks. It'd be great to hear about that as well.
Yeah, absolutely. So I have been doing hospice for quite a while, and before Three Oaks. So I've been with Three Oaks for about 3 years. I think they officially acquired the hospice I'm at about 2 years ago, or a little over 2 years ago. So I worked in an agency where we had an answering service, where it's someone who is non-medical, definitely not a nurse, answering calls from upset families. A patient has died, they've had a change in condition, and it's an answering service. So they're talking to someone who doesn't really understand what they're even talking about. And then they have to take a message, and then take that call and then give it to the triage nurse at the hospice. So basically the family, is having to go through multiple steps. Another thing that I've done before is I've worked for a very small company where when it was my turn to be on call during the week, phone calls came straight to me, which kind of seems like it would be a good thing because it's going straight to a nurse who is in the field. but that was the problem. I was in the field. So I could be with another patient, I could be at a death, and I'm having to answer a call. And it could be from a family who's upset, who needs something. So those are truly the only two other experiences other than my new one with IntellaTriage that I have. So yeah, they were,
Excellent.
just extra steps.
Yeah. Yes. And so, yeah, to Christy's point here, there's a couple of primary models here, and we'll get into some of the pros and cons here in a second. But the three most common models that we see, either the on-call nurse handles all the calls. So again, this is where your phones are rolled over after hours directly to whoever is on call. Typically, there's an on-call number that it's routed to, and that nurse is responsible for maintaining that phone. Sometimes it's routed to their individual cell phones. Happens a variety of different ways, but kind of the spirit of this model is that the on-call nurse is the one who's actually making the visits and taking the calls. To Chris's point, the answering service is kind of the most traditional model that we see, where you just have a non-medical answering service taking the calls. So patients are getting to someone quickly, but then they're not being able to get routed directly to a nurse, so that the answering service takes the call down, records a message, and then forwards on to the on-call nurse. So again, the on-call nurse is seeing every single call, just over a little bit less of a time frame as far as taking themselves. And then finally, the internal triage nurse, which is a nurse who's dedicated to not going out in the field, but actually just taking the phone calls and then dispatching out to the field. And again, that's getting a little bit more common in the market, but we do see significant costs that we hear about required to staff this model, and also you have to worry about if your triage nurse is off, what do you do? So wanted to go through just some high levels and pros and cons. I think generally what we're trying to do here is not say one model is better than another, but we really do want to increase visibility into the options of the models and really increase the visibility into what the pros and the cons are and the trade-offs that each make. I don't want to read through these individually, but I think at a high level, and again, I think we'll send this presentation out, but I think at a high level, what we see here is there's a trade-off between this triangle of patient experience, your own internal nurse satisfaction, and cost. And all three of the most traditional models kind of layer in different pros for those and different cons. So as an example, an answering service really doesn't do much for burnout because your nurse is still getting all of the calls. Now they can pace that out a little bit. If they're at a death visit, they don't have to get that call right then. They can pace it out to after the visit, but they're still getting every single one of those calls. So still 222 of 222 calls are going to get routed to that nurse at some point. What we do see is kind of fast answering times for answering services. Generally, we'll talk about the metrics that you should be looking at the end here, but generally you talk about a speed to answer of somewhere between 15 and 30 seconds for answering services, and they're really cheap. So, there's pros and cons to each model here that I'll let you read through. I think it's just something we're trying to increase a little bit of visibility on. And I know Christy spoke to at least a couple of those models just a second ago. So with that, we'll kind of go into, we've talked about, the models that there exist, the burden of after hours. So how can IntellaTriage help? What other options are there out in the market that could potentially help alleviate and provide a lot of benefit to all of the stakeholders in your ecosystem? So both your administration, your nurses, and your patients. And so we want to start out with just kind of a little bit of a fast fact, and then I'll bring in Christy again. And kind of the fast fact is, did you know that 65% of after-hours calls on average can be handled by an outsourced registered nurse? I think most customers or most potential customers are surprised to hear that number. Across our entire hospice home health census of over 10,000 patients, we see an average of 65%, as high as about 80%, and we can get into kind of what drives that difference here in a few slides. But I did want to bring Christy back in here to kind of talk about her experience since being at 3 Oaks with IntellaTriage. I know you talked about it a little bit, Christy, but if you could maybe talk a little bit more on the impact you've seen from us being able to answer or address 65% of those calls.
Yeah, definitely. So, and I mentioned this earlier, it's knowing that the phones after hours are being answered by a registered nurse who has access to our electronic medical record, is able to document in real time, can pull up a patient's chart, see what's going on, see if there's any alerts. It gives our nurses a peace of mind. They know that the patients that they're calling after hours, that they are truly going to get the best answer possible in real time. And they're going to know immediately when they wake up in the morning, because we get a report every morning. And of course, there's documentation in the chart. So the nurses, it gives them just that security of being able to just turn off their phones at 5. Another thing is we tell our families, we tell them, you know what, you have access to a nurse 24/7. But that also means when you call after 5, you're actually going to be talking to a registered nurse. You don't have to talk to someone, give a message, wait for a call back. You're actually going to be talking to someone. And then on those occasions that the triage nurse is not able to triage the call because either they need a visit or something is going on that requires further action from us, I mean, they immediately call our staff. We have protocols in place with IntellaTriage that we set up and tweak every once in a while. And so they just get the next call they get is from our staff. So it feels like a team. It feels like IntellaTriage, yes, they're not here physically, but they do feel like part of the team. We get pretty much the same nurses most of the time. So it's our staff after hours and on the weekends actually even develops relationships with these nurses, which is kind of fun when I don't, if I have to get a recording of something for any reason, like hearing these conversations, because you can tell it's like teammates talking. So I mean, it's truly a team.
Yeah, absolutely. Could not agree more. I think our nurses say the same thing, Christy. And so, we talk about. I wanted to talk a little bit and dig into the 65% and what that actually looks like. So we have a couple of different cuts of data here. So one thing I'll kind of preface this with is at IntellaTriage, we're a little bit of data nerds. We like to really understand what happens after hours, what kinds of calls come in, what kinds of calls come in, how we can help your team as best we can. And so we break out a lot of data in a bunch of different ways. So using our hypothetical example of an average customer, where we had 222 calls during an average week, again, around 145 of these calls, or 65, is going to be able to be addressed by us. The question we most often get next is, okay, so what happens to the other 35%? Well, of the other 35%, that's broken out kind of pretty much equally 50-50 between what we can say the hospice is a hospice managed call, where we have to notify you. So you can think of that as being maybe a death call or a referral call, something like that, something that we're going to let your field nurse know kind of no matter what. And then of the other half, we would say this is where we have the most flex. So I said we have kind of up to 80% addressable calls. This is the what we consider, hospice managed visit likely required, but we can be pretty flexible. The example we always give here is we like to be an extension of your team, and we like to your clinical directives, can be customized to kind of whatever you see fit for our nurses to handle. So again, the example that we always use is falls. Some of our customers have us call for all falls. If someone calls in to report a fall, we notify their on-call nurse. Some only have us notify them if it's a fall with an injury or a fall that needs a lift assist. And so that kind of detail goes across a ton of categories and really helps us act as an extension of your service. And it helps us, if you want us to be a little bit more aggressive on our triage, we can address even more of your calls. If you want us to be a little bit more conservative because you have a patient relationship where you just want to be high touch, we can do that as well. So that's just one cut of the data we have. And I think the question that we get most frequently next is, so how do you do this? And so I wanted to touch a little bit on just what we do when we triage a call. And I'll start off with saying it's not that different than what you would do or your nurses would do if they were the ones taking the call themselves. We kind of bucket things into these 6 major buckets, but I think there's a lot of detail in these, and we'll get into a little bit of a cut of data on the next slide as well of what this can look like. But I think by far our most common types of calls are these first 2, which is kind of the pain and symptom management and emotional support. So again, I'll go back to my own personal experience with hospice, which is you really just don't, if it's your first time going through hospice, you don't really know what to expect. You have questions, and again, whether that's 3 a.m. or 3 p.m., if there's a change in condition or breathing gets labored or there's gurgling, you have these questions that you really just need emotional support and people to talk through with what's going on and understand that this is normal, or maybe this isn't so normal. And we'll get a nurse over there. So we be sure to take a kind of an active approach in that emotional support and then the pain and symptom management. Some of the other things that we do fairly frequently and we see as pretty high impact just because it takes the workload off of your team is medication refills and DME ordering. So again, we access your systems, so we can call your pharmacy, we can call your DME company after hours within the scope of what you want us to. So if there's certain things in your formulary you don't want us to order, require special approval, then we work with you to understand what that is. We don't do medication orders. I think that's part of, we don't want to have any kind of gray area with the conditions or participation for CMS, but we do refills for medications that are already in the medication profile. So as Christy mentioned, we do access the EMR directly in your system. So we have the most up-to-date patient information, and we can do those medication refills as needed if it's already ordered. One of the things we also do is a medication follow-up. So if we advise a different dosage of medication, so maybe morphine is prescribed up to a certain amount every 1 hour, but the caregiver's only been giving it up to every other hour, and we advise, hey, why don't you go ahead and try every hour? We then will call back 30 to 45 minutes later and make sure that that was effective. And if not, we can follow up with the field nurse to make a home visit. And then lastly, but certainly not least, is referral capture. We do like to differentiate this between intake. But the lifeblood of any hospice is the referrals, and sometimes those come in after hours. So sometimes it's 5:15, sometimes it's midnight. But what we do is we take down the standard referral information to get back to your intake team. So that way it feels from a caregiver perspective as if they've already kind of engaged with the hospice. They're less likely to look for another hospice in the area, and it allows your intake team the time to actually get out there to the home and process the referral. Christy, anything to add there, or any of these areas that you've noticed have been particularly helpful for your team?
Yeah, actually, I was thinking about on the other slide too, about all of the data that you're able to give. It helps me as the director able to pinpoint what is going on with our staff, what they need education on. For example, I was really concerned about refills because we've changed our pharmacy recently, and apparently our refill calls were down. I think I wrote it down. They were down like 25% from the month before. So, that was good to hear. But it lets me know, like, if I see a bunch of refills after hours or a bunch of calls about what to do for pain, then I know that I just need to kind of give some reminders to my staff to really work on that during the day. So that it really helps with the education, my education.
Yeah, absolutely. And great segue for me there, Christy. Thank you. So, we also kind of break out, as Christy was mentioning, what each of the calls looks like after hours, and we group them into categories, but then we subcategorize them. So we have the clinical calls, which are almost always the highest incident of calls that we get. And right here this is across, again, it's a little bit dummy data, but it's really blinded across all of our hospice customers of, hey, 38% of your calls were clinical. And then we can break that into, well, here's yet this percentage of calls was bowel bladder, or this percentage of respiratory. And so something we were able to do since the beginning of COVID is actually trend historic data with kind of real-time data around respiratory calls. And we saw a sharp uptick in respiratory related calls due to just everyone's sensitivity to COVID. And so having that kind of real-time insights is helpful, to Christy's point of just letting your team know. As Christy mentioned, we talked about the medication. We break this out into, hey, is this a refill call, or is this an information call? And if we're seeing kind of a departure from what we see across our overall average or your historic trends, we're able to dig in there and say, here's what we're seeing over time, and maybe you could provide this education to your team. So really, we look at this as a partnership process, and really wanting to be able to provide as much data to you after hours as possible, so you can make informed decisions during the daytime care, and vice versa as well. And so I know we're going to talk a little bit more specifically about our encounter, or our partnership with Three Oaks. This was an interesting quote that I think Christy had when we were talking, is kind of how hesitant she was when we started. So Christy, maybe you could just provide a little bit of background around that hesitation, because I do think it's something that is common. People just have that worry and unfamiliarity.
Absolutely. Because up until I came to Three Oaks, I was dealing with answering services or, a nurse or myself answering the calls after hours. So I know when I first started here and they're like, oh no, we have a triage company. I'm like, what? I was like, there's no way this can be good. I just don't see how, it's a nurse from who knows where and, answering calls on our patients. And I mean, and I truly did. It was probably within my first month of me being here that I realized, oh, okay, they're part of our team. They have access to our patient information. They know what they're talking about. I mean, they're hospice nurses. They understand. We have very, I don't want to say strict, not strict, but we have a lot of protocols in place for different things, kind of like, when to call us, when not to call us, when to send a nurse. We even have it down to by facility on some of our patients. Like if anyone from this facility calls, you send someone regardless of what it is, unless it's like a refill maybe. So yeah, I can't imagine now not having a triage company. Like I can't imagine going back to one of the older models that I had used before. It's been great. And I know, like I was thinking about examples the other day, and I live in the Dallas area, so sometimes we have tornadoes around here. And I remember we were about to close the office down for the day, and I reached out, and it was probably last minute, and I was like, is there any way y'all can take our calls? Otherwise, we were going to try to triage ourselves until 5. And I mean, within like 30 minutes, I had it set up, which may not always happen because it was in the middle of the day, which are not typical triage hours. But I mean, I was basically told, oh, we're going to do whatever we can to help y'all, to support you, to get y'all home so you're safe. So that's
excellent.
My hesitance went away.
Thanks for that context, Christy. So I thought what we wanted to do next is kind of walk through the tactical, hey, what this looks like, because I think that's where there's not being familiar, there's a lot of hesitancy, and so the more familiar we can get with this model, the better. So we thought we'd just kind of walk through a sample workflow here of what this looks like, and I'll provide a little bit of detail. Christy, to the extent that you have something you'd like to add on this, please just jump in and kind of you can talk about how it works internally or tactically as well. But I think generally the process goes something like this. So the call forwards directly to us. So after hours, 5 p.m., most of our customers have an automatic rollover from their phone system, and it forwards directly to either a queue or several queues for your organization that routes it to IntellaTriage. One of the things that we always pride ourselves on is really being an extension of your service. So there's always going to be a customized greeting with your hospice's name, and really making sure that it feels like, hey, this is, in this case, Three Oaks Hospice answering, not just some nurse and who knows where. But the second part of that is, and something that we think differentiates us pretty significantly, is that we always have a licensed registered nurse answering the phone. We don't have patient coordinators, or there's a bunch of different names for them, but essentially non-nurses answering the phones, and that routes the calls or tries to get the call to the appropriate priority. We always have a licensed registered nurse answering the phone. We don't have anyone else, and we also don't have any voicemail, so it's always going to be answered by a licensed registered nurse. I'll note here, and I'll talk about the metrics here in a little bit, but on average, our calls are answered. We look at wait time versus speed to answer, which I'll talk about again in a minute. But our average wait time across our entire company for all of last year and year to date is 40 seconds. So very quick to actually get to a nurse. And we always ask our customers, like, think about speed to nurse, not speed to answer, but how long does it take in your current process for on average to get to a nurse? Or what are your outliers for how long it takes to get to a nurse? So if you have your nurses answering and one of them is a home visit, what does that outlier look like as far as how long it takes a patient to actually connect with the nurse? And for us, on average, it's 40 seconds. So from there, as Christy mentioned, we do have access directly to your EMR. We know that charting sometimes happens after the end of the normal workday, and if you do a push-pull integration where you're pulling out all the records at 5 p.m. and then pushing them back to you at 8 a.m., you may not capture the most recent encounter with that patient, and it's not surprising that a lot of the times the patients who receive visits that day, because of either they're declining or had a change in condition, or oftentimes the ones who call in. So having that up-to-date and real-time information is really important. So our nurses review the patient record directly in your EMR, We have experience kind of with all EMRs, or I should say the vast majority of EMRs. I'm sure there are one or two that we haven't come across yet, but the vast majority of EMRs, we access that and also chart from there as well. Christy, was that new to you as far as like accessing the EMR and having that real-time exchange?
Oh, absolutely. Because the answering service, at least the ones I've worked with in the past, didn't have access to EMR. So when I heard that, I was like, oh, this is even better. They're actually going to document in my system. This is amazing.
Yeah. So yeah, it's an important thing. I think important part of what we think is good communication back and forth is that real-time communication or most up-to-date chart review and for your vice versa for your nurse. From there, after we reviewed the chart and medication profile, the plan of care, our nurses, as Christy mentioned, we have hospice home health trained nurses. We don't just have any nurses, but we actually have nurses that have significant experience in these specialties. So for our nurses, we have over 20 years of experience on average for nursing experience, and over 8 years of experience on average for our hospice experience. So these really are well-trained and seasoned hospice nurses, not just a nurse coming out of nursing school who's taking the calls. So we're able to triage those calls, referencing all of the clinical directives that we've developed with you, again, to act as an extension of your service and provide the care instructions back to the patient and the caregiver. We have then what we call the work of the call. So the work of the call really is a broad bucket term for everything we do that is after we hang up with the patient. So that could be ordering a medication, or refilling a medication, ordering new DME, contacting the on-call nurse because of the death visit. All of that stuff falls into that perform the work of the call bucket. It's quite varied and quite detailed depending on how specific you want to get for your patient population or different facilities. As Christy mentioned, we even have it for them at the facility level. This specific facility calls, we do this. So that's all falls into the perform of the work of the call bucket. 6 is that documentation step. Again, we want to make sure there's no gap in communication. So there's actually 2 different pieces of documentation that we do. The first is in the EMR, so that way all the notes are up to date and your team has access to kind of the encounters that happen in the middle of the night. They can review those in the morning when they get up. The second, which Christy will talk through in just a couple of slides, is our daily activity report, which is really just a summary of the report that is I think really helpful for the team and kind of understanding what their work is the next day, because they can see who called in. And then finally, I already mentioned this, we're kind of data nerds. We are always trying to take a look at analytics and provide opportunities for continuous improvement for ourselves, for our customers, and really making sure that we're all aligned and kind of providing the best possible patient care possible and providing the best patient experience. Anything you want to add there, Christy?
No, I don't think so. Not on this slide. I'll probably, because if I start talking now, I'll mess up the next slide.
So I will now let Christy kind of talk through. We wanted to make sure we provide a tactical example of what that looks like for the Three Oaks team and how they're structured and how they work with us. So Christy, if you want to take it away.
Yeah, absolutely. So during the week, how we have it set up is IntellaTriage is the person there. They answer the calls, of course, and then they call our nurses directly. We've got, well, we now have actually 3 RNs on call each night. We just added a new one. But we have 3 RNs and they just kind of rotate through each one. They know ahead of time if we've got visits that are already scheduled. And so they will skip that person and go to the next one, and they just kind of go into a rotation. We have an AOC or administrator on call every single night of the week and on the weekends. And I rarely do I get a call. If I get a call, it's usually a complaint call or a facility, or there's a death and both my nurses are at admission, and they'll be like, who should I send? We just kind of talk it through. I think the last time I got a call was last Tuesday. And to me, this was a great example of how we were like a team, and like we were able to tag team this situation. I had an issue with some triplicates for some morphine, and the family was needing it. So I talked to the triage nurse. I was like, okay, I'm going to call the pharmacy. I'm going to improve the stat. You do this part, and then we'll be done. And that's what we did. I took a piece, she took a piece, and it was great. It was just a good way of, just a good example to me of how we work together. And the type of calls I get during the week, which is really not very many personally. On the weekends, we do it a little bit different because weekends are so much busier and we have double the staff on the weekends. So we actually have our own, we call her a triage coordinator, who it's one nurse who takes all of the calls from IntellaTriage. So the triage nurse, the IntellaTriage nurse, is still attempting to triage the calls. So my triage coordinator is not getting all of these calls. She's only getting the ones that need visits. And then that person assigns what nurse is going to go out, because we just found that, you know, having 6 nurses working during the weekend, it's hard to keep track. So we have one designated person on our staff who does that, and it works really well. Both plans are a little bit different, but it works. I mean, it just works great for us.
Yeah, we affectionately refer to the weekends as the air traffic controller, so we can she coordinates everything for us. So
yes, and we have pretty much the same person every week who does it. Sometimes it's someone new, and again, she'll tell me, she's like, oh my gosh, I love the nurses who are on this weekend, and we would just develop relationships with these people because we, you know, when we talk to them. And then every day we get a daily activity report. So before I even come into the office, I already know, and I don't know how it is possible, but I swear I get it at 8:16 every single morning. I don't know if it's just very, I don't know. I just know at 8:16 I'm getting my report, and it looks just like this. For us, part of how our calls are arranged is we have teams. We have currently 14 colors. We're about to move to, I think we're going to have a total of 17 colors in the next week or two. And so we can quickly see, usually on the far left, it'll say our team color. And that way we know, you know, what team is having a lot of calls after hours and what type of call. But I get this every morning. And so I know before I come into the office what happened overnight. And then I can also go into the portal. I think that's what we still call it. Is this still called the portal?
That's it.
Yeah, okay. I was like, I can go into the portal also and pull these different reports. So it's great. It's great to know. I know exactly who the patient is, what happened, and if I need to follow up.
Exactly. Thanks, Christy. And one thing, you know, we wanted to use a specific example, call it a case story is what we usually say, an example when us and Three Oaks kind of partnered recently to make sure, you know, a situation was resolved. And so essentially the high level here is that we had a concern that we received from a long-term care facility that one of Three Oaks patients was residing at. The facility kind of stated the overnight nurse did not provide any guidance on new symptoms, and it was rude. You know, one of the best things about our system is that we record all incoming and outgoing calls, so we have record of everything. And you know, again, we don't think people are intentionally misleading, but we think that high stress situations can leave a lot of room for interpretation on kind of communication. So you know, our nurses are trained to be as precise and kind of over-explanatory as possible, but occasionally we do get a concern. We were able to pull the recording though from this call, and you know, we sent it over to Christy and her team, say, hey, look, you know, we answered, we think it's appropriate, resolved all the triage questions, provided some guidance on medication administration. And so maybe this is something we can use as an opportunity to work with your facility to, you know, make sure we're all on the same page. And, you know, I think that doing that, we were able to salvage a relationship with the facility. I don't want to put words in your mouth, Christy, but, you know, I think overall is it a good outcome for everyone involved, and made that relationship a little bit stronger.
Yeah, absolutely.
So, you know, I think I know we're running out of time and want to make sure we leave enough time for Q&A. So, you know, we'll wrap up here and kind of cover just a few things in the next 2 slides. So number one is like what this means really to not just your nurses, but your families. And number one is it helps reassure them that they're going to have support in their time of need. You're able to say, hey, we have 24/7 access to a registered nurse, access to patient records. They're going to be there quick, and they're going to know your whole medical history as it relates to this plan of care. These are experienced nurses with, again, 20 years of nursing experience on average, with 8 years or more of experience on hospice on average. Number two is the patient experience is just pretty dramatically improved. You're getting to a nurse, so again, time to nurse in under a minute. You're not having transfers between non-nurses and nurses and callbacks or frustrating menus. You're really just calling into your hospice agency, and you're getting us, and we're able to provide that care, you know, anytime, day or night. We're also able to act as an extension of your team through these customized clinical directives, so the patients are getting the same quality of care day or night. And as Christy kind of referenced earlier, we are always tweaking those. Say, hey, maybe we do this a little differently. We have monthly meetings to review these procedures and make sure that we're aligned with what you're doing. And then finally, really helping reduce or even eliminate the stress of after-hours care on your team, which is going to allow them to provide better care during the day. It really allows them to kind of recharge in the evenings. Christy's quote around having their case manager's ability to turn their phones off at 5 p.m. I know just has to pay dividends for their mental health, so that when they are engaged with patients, they're really providing the kind of the best quality care that they can. So we do want to provide a few criteria as you're thinking about services like this. I think there's questions you should be asking, whether it's an answering service or thinking about some other model. There's a few questions here that we think you should be asking. So number one is, who answers the call? Is it a registered nurse, or is it someone else non-clinical? Is that all the time? Is it some of the time? What happens there? Is it a first line of defense model? So we always say we have a nurse first model, which means, yes, only a nurse is going to answer first. However, it also means we act as the first line of defense. So when your calls come in, we're that first layer there to make sure that we're addressing as much as we can before we send it back to your team. There's some models out there that are backup models, and that really doesn't do much for nurse burnout, because if your nurse is available, they're going to be getting the call. So I would ask if it's a first line of defense model. If you just kind of tackle things, do you allow customized clinical directives? Do you access our EMR? Do you chart in our EMR? Or is there some other mechanism for doing that? What kind of analytics do you have? And then the biggest thing we always say is wait time. So we like to use what we call as wait time, which is from the time that the caller places the call to the time that we answer, not from the time that it gets to the right queue to the time we answer, which people call speed to answer. And so someone could have a speed to answer of 30 seconds, but a average wait time of 2 minutes, because it goes through a bunch of different queues before they're measuring that. We like to measure what it looks like from the patient's perspective. And so our average wait time is around 40 seconds. Our average speed to answer is actually closer to 28, 29 seconds. So just make sure you're asking those distinctions. And then also, hey, do you have experience in the hospice and home health space? And who are your customers? Are they willing to provide references? I think that's the best way to get comfortable with the provider. We'd love to talk with any and all of you about your after hours care. We'd love to, it doesn't have to be engaging, saying, hey, talk to us about your service. We are happy just to engage in a kind of what we call a strategy section to understand what your model looks like, where, what kind of data are you collecting now? Are there areas for improvement? We also have a special report on this very topic as well. It's linked here. We'll send this out. But please reach out to myself. We have a contact form on our website if you want to reach out there as well. We'd love to get in touch and just learn more about you and your organization, and if we can help. So with that, we'll turn it back over to Jim for Q&A.
Okay.
Thanks so much, Christy and Daniel, for your insights today. Really appreciate your being here. We do have a few questions to get into, and as a quick reminder, you can submit questions through the box on your GoToWebinar app. But first, would you like me to run through the numbers from your second poll?
That'd be great.
Excellent. So the question was, what's your current approach to managing after-hours calls? 64% of our participants voted, and we have 50% said they use an answering service, 30% use an internal triage nurse, 9% said a field nurse answers all calls, 7% weren't sure, and 4% said other. So we can, moving into the questions, there seem to be other services like this in the market that don't use the nurse first model. Why is that the model that you use for this service?
Yeah, that's a great question, Jim. I would say this goes back to kind of our over a decade of experience at this point. I know our founder, Susie Meshbach, who's still with the company, when her and our first employee, Kathy Blazek, who's currently our chief nursing officer, were kind of building this service, they tried a bunch of different things. They tried patient coordinators, they tried kind of the non-clinical person first, they tried being a backup version. And I think what we found is, if we're trying to address the issues of nurse burnout and patient experience, you really do need a nurse answering right away, and also a nurse not going in a roundabout way through to that nurse. So, I think what we found is that nurse first model really does help reduce the burnout. If as a backup model, the field nurses are still taking all the calls unless they're in a home visit, and that really doesn't do much for them being able to not have that after hours burnout. And we also just felt like, through experience, is shown with whether it be CAP scores or patient satisfaction scores, that just being able to get to a nurse really quickly, right away, just dramatically improves patient experience.
Thank you. And do nurses need to learn a new technology platform in order to get the benefit of this service?
Another very good question. So the short answer is no. We do not. We know that there's always new technologies coming out, and we look at that as a little bit of a burden on your team, having to learn yet another piece of technology that they interact with, outsourced team on. What we really try to do is live in your current process and current systems, so that way they're not having to learn anything new, and there is no learning curve there for our team or your team.
Excellent. And what can you tell us about the cost of the service?
That's what, I think this is the most common question we get at this point. What I would say is it depends on a lot of things. It depends on size, depends on hospice versus home health versus palliative care, depends on coverage hours, depends on a lot of things. What I will kind of say as a blanket statement is this service is less than 1% of your daily reimbursement for your patients. We intentionally try to make this as affordable as possible because we think it's a great service and adds a lot of value and want people to be able to use it. So I can say it's less than 1% of daily reimbursement for hospice.
Thank you. And how does your solution integrate with a hospice's secure messaging platform?
Another good question. So depends on the secure messaging platform. What I would say is generally right now we do that a little bit, but generally we try to rely on phone calls. What we have had experience with in the past when using these secure messaging platforms is sometimes a nurse doesn't get the message, or we're unsure if the nurse gets the message, and then something falls through the cracks. So we try to be really active on our communication and just make a phone call. And if they don't answer, we leave a voicemail, we wait, we call back. If they don't answer again, we can escalate again. This is all part of the clinical directives, but we really do prefer the phone call method because it ensures that what has happened is being accurately communicated and is being received.
And have you seen a significant impact on, CAF surveys, satisfaction surveys?
I can speak to that a little bit, but curious if Christy has any insights there.
I do. Actually, I was just looking at my year-to-date FOSI report, and our ratings on the after-hour attention, basically I can't remember the exact question, we're above the national average on the families answering definitely yes, that we are responsive. So that's including, of course, triage and our nurses who are actually making the visits.
Yeah, thanks, Chris. Important context is like after hours. There's a couple questions specific to after hours, but it's the whole team, not just IntellaTriage. What I'll say is we actually have a case study with a hospice in the Mid-Atlantic region that they went from about a 10-point below average CAP score on after hours to about a 10-point above national average on the CAP scores for after hours. So we've seen significant movement on several of our clients.
Excellent. I'm going to try and squeeze a few more questions in before we run out of time. We have quite a few. What percentage of calls have to be routed to the on-call staff after speaking with IntellaTriage?
Percentage of the on-call have to be up. So that 35% on average go to the on-call staff. So we're usually able to address that 65%. There's some wiggle room there. So we do have a few customers that are closer to the 80%. We have a few customers that are closer to that 50%. It really depends on the clinical directives we develop with your team on how attentive you want us to be. Christy, does that kind of resonate with kind of usually what you see?
I was just thinking back. I know last month we were, I think, right at 65%. I think we're usually between like 64 and 70% is handled by the triage nurse, which is great. Very good.
Excellent. And Christy, the next question is directed at you. You spoke of being able to use the analytical data to focus your education.
Mm-hmm.
What do you think has been the most significant impact on your QAPI findings?
You know, honestly, it goes back to medications. Medication and refills after hours always seems to be such an issue. So being able to tell the staff, you know, like this is the number of calls that are coming in. We need to focus on making sure we tuck our patients in for the weekend, making sure that they have all the medications they need. If that means they need to organize the meds and not just rely on a facility or a family to give them the refills. It's made us be able to streamline our process for getting refills taken care of. That's probably one of my best examples because that just seems to be such a, maybe it's just one of my pet peeves, but when I see a refill call after hours, I'm like, I reach out to the nurse, like, what happened? Like, you know, where did we mess up here? So that answers that.
Thank you. And does IntellaTriage serve only hospice providers, or does that extend to other types of organizations? And if yes, how are those triage models different from what you see in hospice?
Yeah, so we don't just serve hospice. We have two segments of our business. We have what we call the nurse triage side of the business, which is all things post-acute, so home health, home infusion, palliative care, hospice. And then we have another service called Nurse Advice Line, which is health plans and provider groups. You know, I think the biggest difference in the two different service lines, the goal of the nurse triage service is to make sure the patient is getting the right care after hours. The goal of the nurse advice line is to make sure the patient is getting to the right level of care. So avoiding, you know, ED visits or urgent care visits, making sure if they can take care of it at home, they can. So it's just slightly different goals for both models. But I would say there's a lot of similarities as far as the actual workflows, and we're very kind of, we call it a tailored approach. So we customize those clinical directives to meet the needs, whether it's palliative or hospice or home health. Thank you so much. Thanks again, Christy.
You're welcome. Thanks.
Thanks all.